Firstly, thank you so very much, Jane, for the invitation to come and speak at this conference, and a big congratulations to you and your team. It's just fantastic to see how much great work has been done in rural areas. I grew up in Hamilton, which is just a few miles to the west of here, and I just know how important sexual health care access is for those growing up in rural areas. So I'd like to firstly acknowledge the traditional owners of the land and pay my respects to their elders past, present and emerging. And also I'd like to acknowledge our Torres Strait Islander and Aboriginal colleagues who are here today. So I'm going to be talking about what's new in STIs, focusing largely on chlamydia. So I'm going to touch a bit about giving an update on the epidemiology of chlamydia. I'll talk a bit about chlamydia control and primary and secondary prevention. I'll then focus on where I think we need to put more energy into in terms of chlamydia control, and that's case management. And then I'll touch at the end on current issues for concern, particularly anorectal chlamydia infection in women and chlamydia treatment. And the bulk of my talk and what I'm covering on will really focus on chlamydia control within young adults. So we all know chlamydia is the most commonly diagnosed bacterial STI globally. And this figure here shows chlamydia diagnosis rates in several high-income countries over the last couple of decades. And as we all know, the rates have been increasing quite steadily. But in the last couple of years, things have changed a little bit. There's been some plateauing of diagnoses, as you can see here in Australia and some of the other countries. And in the last couple of years in Australia, the rates have started to increase again. So things are changing a little bit. Now, because chlamydia is asymptomatic 80% of the time, unless you test for it, you're not going to find it. And this figure here shows the correlation between chlamydia diagnoses in Australia and chlamydia tests that are done. And it's a pretty much so a linear relationship that suggests the more you test, the more you're going to find. So I think the main reason why we've seen our chlamydia diagnosis rates increasing year on year out globally is because we're doing a lot more testing now everywhere than we did a couple of decades ago. However, the pattern of the age and the sex profile is changing in Australia. And the figure on the left shows the chlamydia diagnoses by males and females separately. And you can see up until 2015, there was a lot more chlamydia being diagnosed in the females than in the males. But over the last couple of years, the rates have increased quite considerably among the blokes, and it's now almost like a 1-to-1 ratio. And I think part of the reason for this is we're doing a lot more testing among men who have sex with men, particularly those who are accessing the pre-exposure prophylaxis for HIV. And so therefore we're diagnosing a lot more rectal chlamydia in men than we have before. And if you look at your figure on the right, the age profile has changed a little bit. If you look at the men, we've gone from about 3/4 diagnosed in the under 30-year-old age group, dropping down to about 63% between 2010 and 2017. In contrast, most chlamydia diagnosed among women is in the under 30-year-olds, and that's still maintained at over 80%. So what do we want from chlamydia control? And this is a schematic that sort of looks briefly at the natural history of chlamydia. So if left untreated, chlamydia will progress to PID, and that happens in about 10% of the times we have chlamydia. If the PID is allowed to cause damage, it can cause tubal pathology, which increases the woman's risk of ectopic pregnancy and tubal factor infertility. So what we want from our chlamydia control is to halt the progression of chlamydia onto PID. We want to halt ongoing transmission in the population, and we want to halt reinfection that happens. Now, chlamydia reinfection is really, really common, and in women, it's the leading cause of chlamydia-associated pelvic inflammatory disease. Studies have shown that among women attending GP and STI clinics, but up to 30% of them, or 29% of them, will retest positive for chlamydia within 12 months of initial infection. And in our own data here in Australia, in general practice, 18% of under 30-year-olds will be diagnosed with a repeat chlamydia infection within 4 months of their treatment. And this is a concern because repeat infection does dramatically increase a woman's risk of pelvic inflammatory disease. Data from data linkage studies has shown that one chlamydia diagnosis increases a woman's risk of PID by 50%. Each repeat infection increases her risk by a further 20%. And alarmingly, the risk seems to be greater in our young women, with a 5-fold increased risk of PID in our under 16-year-olds. So what do we do for chlamydia control? And we normally think about our interventions in terms of primary prevention and secondary prevention. Our primary prevention are our sexual health promotion, our education, our condom use. And these aim to prevent the occurrence of chlamydia by encouraging behaviour change, by increasing condom use. However, when you look at the evidence, the clinical trial evidence of how effective these interventions are, they're not especially effective for reducing chlamydia infection in the underlying population. However, they are the cornerstone of public health response and they will have some impact, so they're a very important part of what we do and how we approach it. When we think about interventions for secondary prevention, most of the time we're thinking about screening and testing, and some also looking at case management. But if we look at the screening and testing to start with, and what the evidence shows of how effective screening is on reducing the incidence of PID in women. Now, a few years ago, we ran the Australian Chlamydia Control Effectiveness Pilot, the ACCEPT trial. And this was a trial of a chlamydia testing intervention that aimed to determine whether or not if we could get testing rates up to high enough levels in general practice, would we reduce the burden of chlamydia in the population. And we had up to 4 rounds of testing. Now, this intervention was effective at reducing the incidence of severe PID, hospitalisations. And that incidence rate ratio there of 0.65, that means we saw a 35% reduced incidence of PID hospitalisations in those rural towns that were in our intervention group that had lots of testing happening. But we did not see any impact of our intervention on the diagnosis of PID within the general practice setting. So we saw a change in severe cases, but no change in the more common mild presentations of PID. So ACCEPT also looked at the impact of achievable levels of screening on chlamydia prevalence, that is the proportion of the underlying population who had chlamydia at the time. Now, in this trial, we were able to increase our testing rates by over 150%, and we got the testing rates up to about 28% in the women each year were tested. And we were throwing the kitchen sink at the GPs to try to support them. They were receiving incentive payments, they were receiving regular feedback and other interventions, including pop-up alerts. So this result shows, I think, what is possible with achievable levels of chlamydia screening, and we weren't able to reduce the proportion in the population with the infection. So this got us thinking about what we should do. And if we look at Australia and in the UK, which does have an organised chlamydia screening program, and the US, which does have a comprehensive chlamydia screening approach, these programs do tend to focus on let's push testing up as high as possible. And to do that, we monitor how well we're going with diagnosing and how many tests we're doing. And these two figures here and these are chlamydia diagnoses and chlamydia tests that come from Australia's own National STI Surveillance Report. But ultimately, what we really are wanting to prevent with chlamydia control is we want to reduce the reproductive morbidity, because that's what costs money, that's what has a huge personal impact on women and families. But we don't monitor PID. We don't capture it. We don't know how well we're going in terms of what impact we're having. So that's got me thinking that perhaps we need to start looking more closely at case management and how we manage the cases of chlamydia that we diagnose, because we really do want to reduce the risk of repeat infection, because that's probably one of the big factors in causing PID. So case management includes effective treatment, partner notification or partner management, that is to get your partners treated, and retesting those diagnosed at 3 months after treatment to make sure we pick up these reinfections early. So looking at the schematic of how case management can work, if we have partner management, if that's done well, it reduces ongoing transmission in the population. It reduces the individual's risk that they'll become reinfected, and if it also reduces their risk of developing PID if they're female. If we do as the guidelines recommend, that we're retested within 3 months after treatment, we pick up repeat infections earlier, thereby potentially halting the progression onto PID, and we halt ongoing transmission. And I think PID detection or management is also an important component of case management, because when the women in particular come back to see their GP or their practice nurse for their treatment after they've been diagnosed, I think it's a great opportunity to see if we can elicit any subclinical symptoms that could suggest that she might have PID. So ask them a couple of questions. Does it hurt when you have sex? Do you have any pelvic pain? And just, ask that question a couple of times, because we women, we're very good at ignoring these things. So in terms of partner management, as I said, this is needed to reduce the risk of reinfection and ongoing transmission. And there's been some mathematical modelling project that's been done to look at, well, if we were able to increase or double the number of sex partners that we got notified and treated. So if for each person diagnosed with chlamydia, we increase the number of their sexual partners treated from 0.4 to 0.8, that would be much more cost effective than increasing the chlamydia screening coverage. Now, patient-delivered partner therapy, that is when the patient is given some treatment to give to their sexual partner. That's been shown in clinical trials to be really effective at reducing recurrent or repeat chlamydia and gonorrhea infection. But there are ongoing challenges with how that can happen in Australia. It is legal in several states. It's actually legal in Victoria. But uptake is low because of confusion about the legality, confusion about the procedure that's involved, concern about cost to the patients because it does require an additional prescription cost. And there's also increasing concerns about azithromycin resistance, which I'll touch on coming up. So there are also other available resources for partner management. Websites like the Let Them Know website, which Kit Fairley and Jane Tomnay developed years ago at Melbourne Sexual Health Centre. And this is an online web tool that facilitates partners contacting or notifying their sexual partners, and it does enable you to send anonymous text messages. And the message here on the right's one I sent to myself, just so that I can get it into the talk. So we're currently in some work that we're doing. We're looking at, well, can we embed a link to this website in the test request so as that when the nurse or the GP opens up the test result, they could click a link that would take them to it to potentially talk the patient through it. Can we text a link to this website to patients? So these are some of the things we're investigating in general practice. So in terms of strategies to reduce repeat infection, the guidelines for retesting do vary, but the 3-month mark is the key one. So we do need to harmonise our guidelines within Australia. Retesting rates are very low in Australia. Only 20 to 30% are retested within 6 months in primary care, and in our ACCEPT trial, only a third were retested within 6 months. So there are strategies that we need to investigate that could help retesting in general practice. Postal kits, emailing a pathology test request, and these are some of the things we're working through. We're currently running the management of chlamydia cases in Australia. Now, this is a project that we're running in partnership with health departments in Victoria, New South Wales and Queensland, with family clinics in each of those states and primary health networks. And that is looking at what we could do to try to support general practice to improve, make it easier for them to do case management. We're focusing on partner management, increased chlamydia retesting and earlier detection of PID. And we're running a consultation or a workshop in the next session where we'd love to get your feedback. So I also wanted to touch on rectal chlamydia in women because there is increasing interest and concern about this. It's the conferences each year, there's always talk of, well, what are we doing about rectal chlamydia in women? It's a big issue, and we're seeing lots of papers now published in the medical literature saying, well, we should be talking about this. So this figure here comes from a systematic review that gathered all the evidence of everything that's been published to date reporting rectal chlamydia infections and tried to come up with summary estimates. Most of the studies were based in the high-risk setting, so in STI and HIV clinics. But what they found was when they summarised all the data, the median rectal chlamydia positivity among men who have sex with men was 7.9%. But interestingly, among women, it was 7.1%. So very similar positivity estimates between men who have sex with men and women. So this suggesting that there could be a lot of it among women. So this figure here is from a systematic review from Andrew Lau, recently published, and he was interested in, well, what factors are associated with rectal chlamydia in women? And he looked at, well, if a woman has urogenital infection, what's her risk of also having a rectal infection? And it found that women who had urogenital infection had a 32-fold increased risk of also being diagnosed with rectal chlamydia infection at the same time. However, there is ongoing debate as to whether a rectal chlamydia test positive result in a woman reflects a true infection or just DNA contamination from a urogenital infection. The tests we're using these days are so sensitive, they don't require much organism at all. And so just with anatomy, it's easy to contaminate the perineal and the anal area so that you could trigger a positive test result without it actually reflecting a true infection. The other thing that Andrew showed in his systematic review was that rectal chlamydia in women is not associated with anal sex. No association in the studies that have been published. And when he went back and looked at the earlier studies, there was a study published in the 1980s that looked at this very same question. And it also found no association. And the authors then raised the possibility that auto-inoculation from the urogenitals may be the primary mechanism by which such infections are acquired. So a urogenital infection in a woman auto-inoculating and causing a true rectal infection in her. So do we need to worry about them further? So we know that in that review of Andrew's, about 23% of rectal chlamydia occurred alone, so they didn't have a urogenital infection. So if we didn't screen them if they tested negative for urogenital infection, they wouldn't get any treatment, which would mean their rectal infection would remain ongoing. Does that matter? We don't know. Rectal infection in women, if it's asymptomatic and it doesn't go anywhere else, what damage does it do? We don't know. However, if that rectal infection can seed and auto-inoculate and cause a urogenital infection, then it is a big concern because it can potentially lead to pelvic inflammatory disease. It's biologically plausible that that could happen because we know gastrointestinal organisms can cause UTIs. So there are so many unknowns with rectal chlamydia. We don't know if test positivity equals infection. In a lot of women it will, In a lot of women, it won't. We don't know if a rectal chlamydia infection can auto-inoculate a urogenital infection. And so I don't think at this stage we can recommend that we screen for it. There isn't the evidence. We need further recommendation. We need further research. And the fact that most chlamydia is diagnosed in general practice, it's challenging to do or urogenital screening in general practice, requiring an anorectal screen as well might be just too hard, or just a task too hard. So just briefly to touch on chlamydia treatment, there's been a bit of movement in chlamydia treatment and what the recommended guidelines are over the last few years. Currently in Australia, for uncomplicated genital or pharyngeal infection, the recommended treatments are azithromycin or doxycycline. However, the evidence from clinical trials suggests that if the person is symptomatic, doxycycline may actually be more efficacious than azithromycin. For anorectal infections, doxycycline is now the recommended treatment in Australia and also in the UK, and it's about to become the recommended treatment in the US as well. And this is because azithromycin does appear to be about 20% less effective for rectal infections than doxycycline. So I think globally there are increasing trends towards doxycycline as the first treatment for any chlamydia infections. Azithromycin is also causing troubles with resistance for gonorrhea and syphilis. So there's an increasing push away from it. So just to finish up, chlamydia is still the most commonly diagnosed bacterial STI, even though we are testing now more than we ever have before. It's likely that screening does reduce the incidence of severe pelvic inflammatory disease, but does appear to have little impact on the PID that's diagnosed in primary care. There is no evidence that screening reduces achievable levels of screening reduces transmission in the population. Repeat chlamydia rates are high and retesting is low. And I think we need to improve case management so that we can further reduce the complications associated with infection. Rectal chlamydia in women, we don't know. We need more evidence to understand its significance, whether a positive test result is a true infection, can it auto-inoculate a genital infection, and at this stage routine screening for anorectal infection in women is not recommended. In terms of chlamydia treatment, there's an increasing push towards doxycycline as the first treatment. I think because chlamydia is so common and so easily transmitted, chlamydia vaccine development really has to be a priority if we ever want to have true population chlamydia control. And most encouragingly, just a couple of weeks ago, there was the first chlamydia vaccine that was published in Lancet in Infectious Diseases. It was only phase 1, but it showed really promising results. So I think there is a lot of hope there. I just want to have a plug for a survey that we're doing at the moment from GPs to just get their thoughts on case management. Thank you very much.